Okay, I think we'll get started. I'm sure others will filter in as we get going. But welcome back after our summer break. We took the last couple of months off. Many of you, I'm sure, had time to regroup and relax after a very difficult year that many of us have been through with COVID. So welcome back to our virtual seminar series. And I'm very pleased to be able to introduce a colleague of mine. We work very closely together. Many of you will already know her because she's my partner as we deliver these virtual cancer series. Dr. Joanne Kotsopoulous she holds a Canada Research Chair in Breast and Ovarian Cancer Prevention. She's a scientist at Women's College Hospital and an associate professor in the Dalla Lana School of Public Health at the University of Toronto. Many of you probably know about her research. You've probably heard her speak before, but she's really focused on looking at factors that can predict the risk of both breast and ovarian cancer in women with a BRCA1 and 2 mutation. And she's particularly interested in some of these factors that may be modifiable, like diet and exercise and some hormonal types of factors. So I'm going to leave it open to Dr. Kotsopoulous today to talk to us about the latest research that we have in terms of managing your risk of breast and ovarian cancer. And I'll just remind you that you can enter your questions into the Q&A box, and I will be looking at those, and I can bring those to Joanne's attention at the end of her talk. So please, if you have a question as you go, just type it in, and we will get to as many of the questions as possible. Thanks, and thank you, Joanne, for presenting today.
So welcome, everybody. I hope you can see my screen clearly. And thank you, Dr. Metcalf, for the introduction. So as Dr. Metcalf just mentioned, I'm going to be trying to give you a little overview of some of our ongoing research and some of our prior research that is really looking at how we can better estimate risk of developing disease in women with the BRCA1 or 2 mutation, and trying to understand a little bit more about what factors influence risk, with the ultimate goal is really to try to improve upon the prevention options for high-risk individuals. So a lot of this might be a review for some of you, but just to give you a little snapshot of how we manage hereditary breast cancer. So I think many of you may know that one option is screening. So high-risk screening includes MRI imaging or mammography at a yearly interval. There is an option of risk-reducing mastectomy, so bilateral mastectomy. And there's often consideration of risk-reducing agents, so chemoprevention with drugs such as tamoxifen or raloxifene. So those are the recommendations, but what are women with a mutation actually doing to prevent disease? And before I present some data from Dr. Kelly Metcalf, I just wanted to talk a bit about our research program. Many of you may already be contributing to the research that I'm talking about today. And we often refer to this as the risk factor study. So this is a large longitudinal study that Dr. Stephen Narod initiated back in 1995. And for many of you, you may already know if you are a participant. And the way this study works is that at the time of genetic testing, women are enrolled, they complete a research questionnaire, and this is where we gather a lot of the information that I'm going to be talking about today. So we gather information on your family history of disease, your personal history of disease. We ask very detailed questions on reproductive and hormonal questions. And then we follow you every 2 years to update anything and any information that may have changed. So this questionnaire is quite long, but this is really, really a vital part of our research program, and we thank you for contributing. And if you aren't contributing and would like to be involved, I'll provide you with some links later on in the discussion. So since 1996, this map shows us, so the shaded area shows us our contributing centers, and it might be a little foggy here, but what I'm trying to show you is that we have established the largest longitudinal study of mutation carriers, and there are over 17,000 women currently enrolled, and this really represents an important opportunity to be able to conduct our research. So this paper here, or this slide here, shows some findings from Dr. Metcalf's study published in 2019. And it's showing us what women with a mutation were doing before in blue or after in pink, 2009. So we can see right away that fewer women are opting for surgical mastectomy. Very few women use chemoprevention. And for managing their breast cancer risk, we can see that most women are opting for enhanced imaging with MRI and mammography. And for the prevention of ovarian cancer, which I'll talk about in the second part of the study, a lot of women, up to 70%, are opting for preventative oophorectomy. So I'm talking about chemoprevention with tamoxifen or raloxifene, but does it actually prevent breast cancer in mutation carriers? So most of the data and almost all of the data to date is based on trials that were done in women who are at a high risk of developing breast cancer because of a strong family history or other risk factors. And these trials really didn't assess BRCA mutation status. So there have been no large trials conducted among women with a mutation. So we decided to take a look at our cohort to see if there is really any signal to indicate that we should be prescribing this to mutation carriers. So this slide here just shows some unpublished raw data from our cohort. And what we see right away is that there's only about 231 women who were eligible for this study that actually did report using tamoxifen. And we see that most women in this analysis, almost 3,500, have never used tamoxifen. So right away, this really points towards what we already know, that women in general are not electing for chemoprevention with tamoxifen. And we see here in the last column that the percentage of women who develop cancer, breast cancer, whether they did or did not use tamoxifen, did not differ. So although this paper isn't published yet, we're really not seeing strong evidence that tamoxifen may prevent breast cancer. So many of you may know that BRCA1 and 2 were identified over 20 years ago. So there's been quite a lot of research that has been conducted in the past 2 decades. And really, we're still left with preventive mastectomy to prevent breast cancer in this high-risk population. So a lot of my efforts has been in understanding what is influencing disease and understanding the underlying reasons why women with a mutation develop cancer. So maybe we can identify a novel target for chemoprevention. And so there's a lot of evidence pointing towards an important role of progesterone and rank signaling. And so this is an important pathway. And there's a lot of preclinical and clinical evidence suggesting that this is a pathway that potentially should be targeted as a prevention option for BRCA1 mutation carriers. So when we talk about progesterone and breast cancer, we think about 2 large trials, the Women's Health Initiative, that were conducted several years ago. And these were conducted among women in the general population. But what they really showed us is that women who were receiving estrogen alone versus no HRT, so hormone replacement therapy in postmenopause, did not have an increased risk of developing breast cancer. And indeed, there was evidence to suggest that perhaps estrogen alone HRT was preventing disease. In contrast, women that were prescribed estrogen plus progesterone had a significantly increased risk of developing breast cancer compared to women who were in the placebo arm. So again, this provided important preliminary evidence for a role of progesterone in the development of breast cancer. So we've also taken a look at HRT after oophorectomy among women with the BRCA1 mutation. And in this large study which included over 800 eligible women, we found that there was no difference in breast cancer risk among women who did use HRT versus those that never used HRT. And these figures might be hard to understand, but they're just showing how many women develop breast cancer over 10 years. 1 at the top means no one has breast cancer. And as women develop breast cancer, the numbers start to fall. But what was interesting is that women who use estrogen alone, here in the pink, were less likely to develop breast cancer compared to women who use estrogen plus progesterone, which is shown here in the blue. So 22% develop breast cancer versus 12%. Furthermore, this difference in effect by E versus E plus PHRT was even more evident when we looked at women who had an oophorectomy prior to the age of 45. So what these few slides are showing us is that progesterone is also important in the development of BRCA1 breast cancer. And there's a lot of preclinical data, experimental data done in mouse models, and studies that have looked at circulating levels of hormones in women with and without a mutation that have shown that progesterone is indeed significantly higher in women with the mutation shown here in red compared to women who do not have a mutation. So again, this is really suggesting an important role of, or the fact that perhaps dysregulation in progesterone signaling might be an important target. So what our group or my team has been interested in doing is looking at levels of another factor in the blood called osteoprotegerin or OPG. And this exists in all our bodies, in all our cells, and it exists in all women. But there's evidence to show that women with the mutation have significantly lower OPG. So we are trying to evaluate whether this is why women are at a higher risk of developing disease. And my graduate student, Tasneem, has conducted some important studies, which showed that OPG levels are indeed lower in mutation carriers. And those mutation carriers with the lowest OPG had a 31% risk of developing disease, compared to 3% in the women in high OPG. So the reason I'm showing you this is because there's an important drug that exists, and it's called denosumab, and it's currently in use all over the world to prevent osteoporosis. And denosumab acts like OPG to inhibit this progesterone pathway. And there's been a lot of interest in the BRCA cancer world that this drug may also prevent breast cancer in mutation carriers. So really, in review of the evidence, the next logical step for our team and for others interested in BRCA1 breast cancer prevention is to conduct a clinical trial of denosumab in women with a mutation. And what we're trying to, and a real important goal of our team and a very important personal interest is to now consolidate all the research that has been done over the past 2 decades and to see if an intervention with denosumab could prevent breast cancer in mutation carriers. And logistically speaking, this would be a fairly easy trial to conduct. We would have unaffected mutation carriers randomized to denosumab or no denosumab. And here what this graph is showing, or this timeline is showing, is that women are already, undergoing MRI imaging and visiting their clinicians on a yearly or bi-yearly basis. And so the only difference would be administration of this drug, which happens twice a year and is administered by a doctor under the skin. It's known to be associated with a small number of side effects. And we think that this is a really important, logical, scientifically valid way to attempt to evaluate if a drug intervention could prevent disease in mutation carriers. So I'm sure many of you have heard a lot about aspirin and other anti-inflammatory agents. And although there have been no studies yet conducted in mutation carriers specifically, there was a large multi-center study that looked at women with a family history of disease. And there were actually a subset of women who did have a BRCA1 or 2 mutation. And the investigators looked at the role of regular use of some sort of NSAID, so aspirin, a COX-2 inhibitor, for more than 1 month. So this would have to be women who regularly used some sort of anti-inflammatory. And what they found was that overall, these factors did appear to be associated with the reduced risk of breast cancer. In this box B, they're showing non-carriers and carriers separately. And again, although this was based on a small number of mutation carriers, there is some evidence to suggest a potentially protective role of COX-2 inhibitors and perhaps aspirin. But this requires further validation and confirmation, and this is also something our team is interested in replicating. So to summarize this portion of my talk, which really focused on the breast cancer literature, I just wanted to reiterate that we know that there's low uptake of surgical prevention of breast cancer and that most women are opting for MRI imaging, which is aimed at early detection and is very effective at identifying disease at an early stage. But we can't ignore the important emerging evidence that aberrancies in this progesterone pathway is likely very important for development of breast cancer in BRCA1 mutation carriers. One interest for me is whether this level of OPG, a protein that's very easily measured in the blood, can improve upon risk prediction and better identify potentially those women at the highest risk of developing disease, and may be able to better stratify those that should perhaps be opting for mastectomy versus MRI imaging. And finally, we'll rank ligand inhibition, so use of this drug denosumab, prevent breast cancer. So that was a mouthful. I'm going to take a sip of water before we focus on ovarian cancer. So I decided to focus the second half of this presentation on managing risk of ovarian cancer. So this is the second most commonly identified disease in women with a BRCA1 or 2 mutation. And again, I'm starting with a snapshot of the guidelines in preventing ovarian cancer and managing BRCA mutation carriers. So right now, salpingo oophorectomy, so removal of both the ovaries and fallopian tubes, continues to be strongly recommended for women. Salpingectomy, which means removing the tubes only and leaving in the ovaries, is not currently standard of care. And I'm sure many of you know that screening with ultrasound imaging or levels of CA-125, again, another protein marker in the blood, has not shown to reduce mortality. So we recently decided to, again, query our database that I talked about in the beginning of this presentation to see if there was any emerging differences in the ages at which women with the BRCA1 or 2 mutation develop breast cancer, to see if we can better refine the ages of recommendation for surgical prevention. So here we show the lifetime risk of developing disease. So as the numbers increase, this shows how women are developing ovarian cancer. And this shows us the cumulative risk for over 4,000 women with a BRCA1 mutation. We've identified 176 women that developed ovarian cancer. And the mean or average age of diagnosis was 51. But what we see here is that there is a very wide range, as early as age 30 to as high as age 84. So the lifetime risk in a mutation carrier, a BRCA1 mutation carrier, is 49%. So this is extremely high. When we think about the general population, the lifetime risk is less than 2%. For BRCA2 mutation carriers, this slide shows us what we already know, that the lifetime risk is lower at 21%, but still significantly higher than the general population. And the ages of diagnosis are substantially later in women with the BRCA2 mutation. But what this paper that we published a few years ago was very important in showing us is that among women who were undergoing preventive oophorectomy, so 1,500 BRCA1 and 595 BRCA2 mutation carriers, we are identifying cancers at the time of oophorectomy. So about 2.6% of women with the BRCA1 and about 0.67% of women with the BRCA2 were found to have cancer at the time of their preventative surgery. And again, in BRCA1 mutation carriers, these happened fairly early. There were 8 diagnosed between ages 35 and 44. The earliest occult, which means cancer at surgery, was found in a BRCA2 mutation carrier between ages of 45 and 49. So this really points towards the fact that we have to stick within the age-specific recommendations to prevent all disease. And this is important because we know that oophorectomy has an important role in preventing disease. Our team has previously shown that it significantly prevents the development of ovarian cancer, which is intuitive. But what's even more important is that oophorectomy also decreases all-cause mortality. We've shown that oophorectomy for the prevention of ovarian cancer also reduces a woman's risk of dying, from all causes. Since screening is not effective at early detection, this is really the only way to prevent disease right now in women with a BRCA1 or 2 mutation. So what else is really emerging to be an important factor is that ovarian cancer is really many diseases. It's not just one disease. And what we do know is that women with a mutation tend to develop the high-grade serous cancers, which are associated with the highest case fatality rate and tend to be diagnosed at a late stage. And these cancers can either actually develop or emerge from the fallopian tubes or the ovaries. So in the past, we were thinking about ovarian cancer developing as one disease, but now we're realizing that a subset of these are also emerging from the fallopian tubes, which is another reason it's very important for women with a mutation to have both their ovaries and fallopian tubes removed. So I'm sure many of you have heard of the word self-injectomy, and there's a lot of interest in whether there is a role of removing just the fallopian tubes and then removing the ovaries at a later date in these young women with a mutation. So the idea is to be able to prevent cancers that might be arising from the fallopian tubes, leaving in the ovaries to allow for continued hormone production, so preventing early surgical menopause, and then intervening and removing the ovaries at a later date. So this is self-injectomy with delayed oophorectomy. Now, this is very important for the general population. Although ovarian cancer is rare, it is very fatal in women with and without a mutation. And so this makes sense and has replaced tubal ligation in many instances in many countries, and is starting to take the place of tubal ligation. So removing fallopian tubes for permanent contraception or at the time of another surgery. But we're not sure yet whether or not this will be a very effective way of preventing disease and mortality in women with the mutation. And there are a lot of trials, clinical trials ongoing, that are evaluating the impact of interval self-injectomy with delayed oophorectomy. But it is not currently the standard of care. And for women that are electing the surgery, it's really happening where they're able to be followed to allow for age-appropriate removal of the ovaries. So we were currently recently funded, Dr. Metcalf, Dr. Nirad, and myself, and our collaborative team, to look at outcomes following self-injectomy in mutation carriers. Anecdotally, we were hearing about a lot of women and hearing from women directly that they were opting for self-injectomy instead of oophorectomy. And so we really want to have a better understanding of why women are electing the surgery. And more importantly, we would like to be able to follow these women to find out if they are returning to remove their ovaries at an appropriate time, and trying to understand whether self-injectomy has a role in preventing disease. This is a highly complicated study design. I'm going to be showing you some of the brochures for this study. So for this study per se, we are inviting women who are enrolled in the risk factor study already, and they simply have to complete an online questionnaire answering some questions about why they opted for this specific surgery versus having an oophorectomy. And some of you may have already been invited to participate. And we are also asking healthcare providers whether or not they are offering this as an option for management of ovarian cancer in high-risk women. So I've talked a lot about surgical prevention of ovarian cancer because that is one of the factors that we know most about. But I'm sure many of you who are mutation carriers are really interested in the role of other potentially modifiable risk factors to help decrease your risk of developing disease. And what we've known for a long time is that oral contraceptives do prevent ovarian cancer. This is seen in the general population, as well as among women with the BRCA mutation. In a recent meta-analysis, it was shown that oral contraceptive use decreases a woman's risk of developing BRCA-associated ovarian cancer by 42%. It's associated with a reduction in risk in either mutation carriers, and is stronger with more recent use and even persists. So it is, the protective effect is sustained. And when we think about mechanisms about why women develop ovarian cancer. These are the reasons that are purported for women in the general population, but may or may not apply for women with a mutation. So things get complicated. We don't really know exactly why women with the mutation are at an increased risk of ovarian cancer. It's likely that hormones are involved, including gonadotropins and sex hormones. And we also know that oral contraceptives likely prevent because they block ovulation. So it's been shown for several decades that this repeated ovulation that happens every month in a menstruating woman may increase inflammation, cause some sort of DNA genetic damage that eventually develops into ovarian cancer. So there's been a lot of uptake of different contraceptives. Oral contraceptives have been widely used for decades, but we know in more recent years there's an increased interest in IUDs, intrauterine devices, injections, and implants for as a contraceptive method. But there's very little in the literature about whether these contraceptives will prevent ovarian cancer in high-risk populations. My graduate student, Cheryl, who is currently finalizing this analysis, looked at our cohort to see if oral contraceptives continue to prevent ovarian cancer in our larger numbers of women, and whether there's a role of these other contraceptive methods. So here we can see that any contraceptive use is associated with the 42% reduction in ovarian cancer risk. And we can see here that this reduction in risk of about 40% is sustained with oral contraceptive use. When we look at implants, injections, and IUDs, we can see right away there's fewer women who have used this. So although the number of women who use these other contraceptive types is much lower than women who have used oral contraceptives, we are still showing some signal that they may have an important protective effect, especially when we looked at women who use the implant contraceptives and the injectables, although these did not achieve statistical significance. So again, it's important to try to understand how these factors either increase or decrease your risk of disease. But from a scientific perspective, it also provides some insight into how we can potentially find targets for prevention. So we would never tell a woman with the mutation to use contraceptives as her only way to prevent disease. But what's important in the clinical management of these women is that it is conferring reduction in risk. So they shouldn't be worried about contraceptives increasing the risk of ovarian cancer, but is also providing some insight into how hormonal factors are influencing risk. And so our group has conducted numerous evaluations of modifiable risk factors, hormonal reproductive factors. I didn't want to spend an hour reviewing all these studies, but I've summarized them into risk, protective factors, and those that have no effect. I bolded salpingo oophorectomy. This is the most important protective factor. We've shown contraceptive use is protective. More recently, we conducted a large study of breastfeeding. We found a significant reduction in the risk of ovarian cancer. This is also seen for ovarian cancer in the general population and is really bringing up some interesting questions about why breastfeeding so far in the past of a woman's life confers a lifetime protection against developing disease. We've shown that smoking is an important risk factor, as is late age at menopause. And so these other items in pink are some other items that we still want to take a look at and evaluate whether there is a role for BRCA mutation carriers. So many of you know or may not know that oophorectomy, despite the important role of oophorectomy in preventing disease and increasing a woman's lifespan, so reducing mortality, it is associated with many adverse non-cancer outcomes. There's a lot of literature in the general population showing that early removal of the ovaries may negatively impact bone health, heart health, and brain health. And so this has become an important focus of our group, and we work very closely with the Familial Ovarian Cancer Clinic, Dr. Michelle Jacobson, And a lot of the patients for these studies are enrolled in the clinic. And we're really trying to understand the best way to mitigate some of these adverse outcomes. So I'm going to give you just a really quick snapshot of 4 more recent studies that looked at some of these outcomes. One study was conducted by, our recent analysis was conducted by our trainee, Elizabeth Hall. As you can see, we have a lot of trainees at Women's College that we like to engage in our research. And she tried to provide an update to an earlier report to look at how oophorectomy affected menopausal symptoms and sexual functioning among women with the BRCA1 or 2 mutation. Again, the number of women were small. We had 93 women who were premenopausal at surgery and 47 who were postmenopausal, but we were able to look at long-term, so 3 years post-surgery outcomes. And I've summarized the different findings by their menopausal status at surgery. And we see that, yes, there is a decline in sexual functioning, increase in physical symptoms like hot flashes, and that is more sleep disturbances and other physical symptoms. An increase in vasomotor, so hot flashes, only reported in premenopausal women. But what's important to note is that there was no impact on psychosocial factors such as anxiety and stress, no impact on quality of life in premenopausal women, although there was a decline in postmenopausal women. But it's important to see that use of hormone replacement therapy in the premenopausal setting was able to mitigate some of these symptoms. So again, this points to an important role of the aftercare of women after they've undergone oophorectomy, especially among the women who are premenopausal at the time of surgery, because we saw less decline in these factors in the postmenopausal setting. Something else we think about is the impact of surgical removal of the ovaries on bone health. So removing the ovaries means you're removing your endogenous or internal source of sex hormones, specifically estrogen, progesterone, and androgens. And so we know that estrogen is very important for bone health. So along with Dr. Angela Chung, who is really a leader in osteoporosis work, we looked at this same cohort to see if there was an effect of oophorectomy on bone health. And so for many of you who have had a bone scan, the radiologists look at your lumbar spine, your femoral neck, and total hip bone mineral density. And these are shown here, A, B, and C. And we looked at the impact of oophorectomy on bone health in pre- and postmenopausal women separately. So here, 0 means no impact on bone health. Anything below 0 means a decline, and anything above means an increase in bone mineral density. And what you can see very obviously is that there's more of a decline in bone health in women who are premenopausal at the time of surgery. And there's less of an effect in women who are already postmenopausal. So again, there's a role for HRT in maintaining bone health and proper calcium and vitamin D intake. So something we have to keep in mind when managing women undergoing oophorectomy. So this study is a few years old, but it was trying to get at whether oophorectomy increases the risk of anxiety and depression in mutation carriers. So a lot of the work we do is based on questions we get in the clinic. Our genetic counselors maybe ask some of these questions, or things we find in the literature that are reported in the general population. So again, using our important cohort of mutation carriers, we compared women who did have an oophorectomy to those who didn't. There were 506 women in each group. They were similar with respect to all other important factors such as age, cancer status, etc. And what we found was that actually antidepressant use was lower in women who did have an oophorectomy compared to those who did not. And when we ran our statistical modeling, we found a decreased odds so that they were less likely to use antidepressants. So again, this is showing that oophorectomy is not increasing levels of anxiety, or we can assume that oophorectomy will not increase antidepressant use in this high-risk population and cause more harm. And the final study I'm introducing is something that we just published. And again, you may have been invited to participate. And this was really getting at whether an oophorectomy and other factors, so a cancer diagnosis, treatment of chemotherapy treatment, etc., impacts a woman's level of attention and memory. And we were able to pair up with scientists at Baycrest, who are leaders in the field of cognitive assessment, and use an online assessment tool to easily evaluate 4 aspects of attention and memory. And the way this study worked is that we invited women who were enrolled in our longitudinal study. You were asked to sign in a de-identified way and complete this very easy to use test. And this test actually does exist for free. It's called Cogniciti, but we conducted this within the scope of a research program. And there were over 800 women enrolled in this study. And I won't get into the details of the test per se, but it's able to assess different things like memory, attention, being able to match items, make face name recognitions, etc., and come up with a score. And this is a score based on individuals that are at the same age and level of education as a person conducting the actual online test. So we can get standardized scores to the general population. And so we were hypothesizing that oophorectomy and chemotherapy would increase a risk of having a lower score, which means you're having some sort of memory or attention problems. And in fact, we saw the opposite, that women who had an oophorectomy or in breast surgery were scoring higher, and that chemotherapy and hormone replacement therapy did not predict score. So again, this isn't a way to diagnose any underlying conditions. It's just meant to be a screening test to see if individuals are scoring lower than others at their age and level of education, and whether they should be seeking further help from a clinician. So to summarize the ovarian cancer portion of this presentation, I think I've reiterated that lifetime of ovarian cancer risk is high. There's no effective screening currently, so really surgical prevention remains the best option to prevent disease and decrease mortality. There's a very important role of mitigating some of these adverse non-cancer outcomes. So having a close rapport with a clinician, being enrolled in our familial ovarian cancer aftercare clinic, and really trying to find the best way to manage these symptoms does depend by patient. And Dr. Jacobson gave an amazing presentation on this, which you can find online with the other presentations if you missed it. But we do have a lot of unanswered questions. We don't know if hysterectomy at the time of oophorectomy is necessary. We still need to find out if tubes-only surgery will prevent disease and prevent death. I am really interested in trying to see if there's a way to find a more effective screening option. It may not replace oophorectomy, but being able to delay oophorectomy by 5 to 10 years would be an amazing feat for women with the mutation. And really thinking about novel prevention options. So finally, Dr. Metcalf and the team have been trying to really develop a lot of evidence-based resources for mutation carriers and healthcare providers. I've listed them here. We developed an amazing newsletter, which is found on our website. We were able to develop a patient brochure and video to help women understand what they should expect post-oophorectomy. And if I have a few minutes, I just wanted to give you a little example of what this video looks like. Can you see this right now? Hopefully.
Yep, I can see it.
Okay.
Familial Ovarian Cancer Clinic at Women's College Hospital. Have you or a family member been identified as a carrier for the BRCA1 or BRCA2 genetic mutations and recommended to undergo preventive removal of your ovaries and fallopian tubes? This video aims to, number 1, help you understand what laparoscopic bilateral salpingo oophorectomy means. Number 2, explain what discharge from surgery at an ambulatory hospital looks like. Number 3, provide you with important information on the recovery from this surgery. And number 4, explain when you may expect to return to regular activities.
So hopefully you're able to see and hear that a bit, and that's available on our Women's College YouTube channel. So again, a lot of these things were developed to help our patient population and give back to those that are contributing to our research and who are mutation carriers. And again, there's many opportunities to continue to participate. Participation is key. All these studies were based on data from our questionnaires, those questionnaires that you're asked to fill in every 2 years, which we're extremely grateful for. And if you'd like to participate, there's many ways to participate in our overall program and some of these sub-programs. And again, we're hoping to continue this virtual lunch and learn remotely, unfortunately for now. And there are 2 more sessions left, which we'll talk about at the end. And here I just wanted to thank our highly important integral team, trainees, research coordinators, research assistants, genetic counselors. We have a very strong international collaboration, which I've listed most of the key individuals here who also contribute questionnaire information. Our trainees, like I mentioned, have an important role, and our research staff and important collaborators here in Toronto and all over the world. And finally, our funding agencies, which are critical, and our donors to help conduct this work. So I think I'll stop now and take questions.
Thank you so much, Dr. Kotsopoulous. You've covered a lot of information, and I think even for some people who may have heard some of it, it's a really good refresher in terms of what some of the options are to reduce the risk of breast and ovarian cancer. So I'm going to the questions, and there's some great questions. So I'm going to try and get to as many as I can. One that keeps coming up, and I'll just get it right out of the way at the beginning. The previous sessions are up on our website, so please have a look at that. In fact, I think that it will be sent out as part of the email that you receive after this. You'll get an email, and it will have a link to all of those previous sessions. So if you weren't able to attend, if you have family members or friends who are interested in watching those, please share the link with whomever you think might benefit from those. Okay, so let's get to some of the questions, and I'm going to try and group them if I can. So Joanne, can you tell us a little bit about some diet options? Is there any research to suggest that eating certain foods, certain spices, drinking certain beverages have any impact on a woman's risk of breast and ovarian cancer? And could or should those be used in terms of reducing the risk of developing cancer?
So thank you. That's a great question. And a part of my work and my involvement with the Department of Nutritional Sciences does involve looking at modifiable risk factors, so diet, physical activity, and body size. So to put it into perspective, we know that the mutation is the most important risk factor for these women and will be the most important predictor of your risk. That doesn't mean these other factors are not important. So we have published on weight gain. We've shown that women who maintain a healthy body weight are at a decreased risk of breast and ovarian cancer. So it is important that body weight be maintained, not only for the risk of cancer per se, but we know it's important for developing other diseases like diabetes, cardiovascular disease. So although this is important to keep in mind for the clinical management, they would not replace guidelines for imaging and surgical prevention. So we've looked, and again, I wasn't able to present everything. We're looking at physical activity currently with one of my trainees. We have published on alcohol consumption. We're looking to update that analysis. And we were more looking at alcohol from the perspective of whether it's further increasing risk. In our initial report, we found no effect of alcohol. Again, we would not tell women to start drinking alcohol if they don't drink, but at least we saw that with moderate consumption, it was not adding to their already elevated risk.
Okay, great. Thank you. What about denosumab and BRCA2 carriers? We've talked a lot about BRCA1. Will there be a role, or is it scientifically plausible that there will be a role for denosumab and BRCA2 carriers?
So as the evidence emerges, we know that BRCA1 and BRCA2 are not only different genes encoding different proteins, but they have different roles in our bodies. And so the data to date is, so when we look at the experimental data, so the mouse models and the cell culture work is really pointed towards this perturbation or disturbance of this pathway in BRCA1 mutation carriers. It has not yet been shown in BRCA2 mutation carriers. That being said, it does not mean it may not also be involved. For example, the data that looked at the levels of osteoprotegerin, the OPG marker that's involved in the same pathway, was also dysregulated in BRCA2 mutation carriers. So I would say right now there's not as much data as for BRCA1, but there's other targets also that could be applicable for BRCA2 that are not for BRCA1. So without getting too mechanistic right now, I would say the evidence is less mature for BRCA2.
Okay. There's a question about risk of developing cancer after you've had preventive surgery. So I know we haven't talked about mastectomy today, so maybe we can just leave that. But for women who have had their fallopian tubes and ovaries removed as a BRCA1 or 2 mutation carrier, what is the risk that they will go on to develop an ovarian cancer that wasn't diagnosed at the time of surgery? So what is that residual risk?
That is a very good question, actually. So, and that is something Dr. Narod may talk about next week, and maybe we can ask him to comment on that, because so once a woman has removed both her ovaries and fallopian tube, her risk of developing ovarian or fallopian tube cancer is low, almost, let's say, very approaching almost zero. But there is noted in the literature that a small proportion of women may develop what is called primary peritoneal cancer. This was thought to be happening only in women after oophorectomy, but we really don't have a very good understanding of this and whether it's either a fallopian tube cancer that was there to begin with that already spread to the peritoneum and so was diagnosed later, or whether it is actually a primary peritoneal cancer that is initiated in the peritoneal cavity. So although there's a very, very, very small residual risk potentially of this other cancer, it's very not well defined and something that I know Dr. Narod is and others are currently investigating.
Okay, thank you. And there's a question here that I think is really interesting, and I think it's something that many of us struggle with, and it's really understanding some of these statistics that we present. So the question is, if the use of oral contraceptives reduces the risk of gives you a 42% reduction, does that mean if you're a BRCA2 carrier and you have an ovarian cancer risk of 20% or just over 20%, does the use of oral contraceptives wipe out at that risk of 21%? So maybe you can just help to understand some of these risks, Joanne, because it is a bit confusing.
So I agree. And sometimes I'd like to think of it more to put it in a clinical perspective, and that are we adding to your already elevated risk? So for example, something like oral contraceptives whose use is for really preventing pregnancy, can it be used to prevent ovarian cancer, or at least add or delay age of onset, rather than increasing your risk further? So we can see right away that ovarian cancer, OCs, oral contraceptives, have an important role in preventing disease and are not increasing your risk. So women should not be afraid to take it. But we know that there's a little bit of evidence saying that it could be a risk factor for the breast. And this is complicated, and I agree it's hard to interpret. And this is why we are constantly re-updating our literature and saying, does it negate is it worth taking the oral contraceptive if I'm going to increase my risk of breast cancer a little bit more? Further complicating is the fact that some women have a mastectomy, some women don't. Some women have an oophorectomy, some women don't. Some have both, some have neither. So this is why it's important to continue to be engaged with your genetic counselor and clinician to help tailor what you're doing.
Mm-hmm.
So I know it's very overarching, and I don't know if I've addressed it. Kelly, feel free to add to that.
Yeah, and I think it's hard to explain as well. But if you think about that 40% risk reduction, it's really 40% of that 21%. So you're getting your risk down a little bit, but it's definitely not going to zero, and it's always going to be above the general population risk. So you have to keep that risk in perspective when you're thinking about what you're going to do for prevention. Oral contraceptive use doesn't replace the use of prophylactic oophorectomy in women with the BRCA1 or 2 mutation. There's nothing we can do that's going to get your risk down as low as having the surgery. So that's really why the guidelines that we have, the international guidelines, the only recommendation that they really have is that women need to have their ovaries out. And Joanne, she presented those ages today, the difference between BRCA1 and BRCA2. They don't have those similar recommendations for prophylactic mastectomy, but for prophylactic oophorectomy, that's definitely the recommendation. Okay, so let's move on to some more questions. What about symptoms that come along with premature menopause associated with oophorectomy? What should someone do if a woman is experiencing symptoms after oophorectomy, Joanne, from a clinical perspective?
So again, I am not a clinician, although I do study this area. That's why this importance of, sorry, I'm getting some background noise here. It's very important to be in touch, and we're showing an important role of these aftercare clinics where you can really check in with your clinician. And Dr. Jacobson's presentation, feel free to go back to watch her presentation, which was really focused on that. And every woman is different. Again, the unfortunate thing is that women who have had breast cancer are not able to use hormone replacement therapy. That being said, there are other non-hormonal ways that have emerged that can help manage some of these symptoms. And it's not a one size fits all solution. You really have to tailor and change and modify as needed. And these symptoms are real. This is why we're studying them, and we're continuing to study them. We're focusing on other factors, not just symptoms, but sleep disturbances, etc. And it's important to try to find personalized approaches to manage these.
Mm-hmm. That's great. And there's some great clinicians across the country that specialize in menopausal symptoms that if you need to go and see someone, they might be the right people to go and see. So our final question, what is the typical timeline for the development of primary peritoneal cancer after an oophorectomy? Do we have that type of data, Dr. Kotsopoulous?
These are great questions. There are some reports, but the samples, a lot of this is numbers, right? Having enough women to make confident conclusions. Like I said, Dr. Garrett is currently looking at this, and maybe I'll ask him to talk a little bit about it next week or next month. I'm not sure we know, but it is, I can't even make a guess because the numbers have been so small. So I really don't think I can give an accurate.
Yeah. And I think that's an important message, that the numbers are very small. This is a very rare occurrence that we see these cancers after an oophorectomy.
And again, like I mentioned, some of this just gives us more information as to whether all cancers originate in the ovaries, whether they all originate in the tubes, whether they're originating in the peritoneum, and that's separate from the ovarian cancer. Is the peritoneal cancer just metastases from the ovary? There's a lot of unknowns still.
Mm-hmm. There's so many great questions here, and I wish we could keep going. I would encourage you, though, many of these questions I think that we've covered in some of our previous presentations. So if you have listened to them already and want to go back and revisit them, I would encourage you to do that. And if you haven't, please do that, because I know many of these decisions that you're going to be making about prevention are very difficult to make. Many of you may have children who will eventually be tested, and thinking about their decisions that they have to make are very difficult. So we're here to help you. We're here to get the best evidence to you, to bring this research back to you, so you are the ones that can benefit from it. The next presentation we have in just under a month, and 4 weeks from today, is by Dr. Stephen Narod. And of course, many of you will know him. And he's really going to highlight some of the very important research advances that we have discovered over the last 20 years. Many of you may have been involved in this research program for those 20 years, or some of you may be newer. So we're going to share what we have learned over the last 20 years. And again, some of the most important research findings in terms of how practice has changed as a result of what we've learned. So I'd highly encourage you to come and listen to that. And if you're not able to, remember that we record all of these and they will be put up on our website.
And just to add one more thing, oh, sorry to interrupt.
No, go ahead.
Please, so we are trying to give back to the patient population beyond what you get at the clinic. So please make use of our newsletters or brochures. If you saw something you were interested in, reach out. We have a lot of studies that are ongoing. We call them sub-studies. So they're for mutation carriers, but we're looking at different items. And please feel free, you will be receiving a link to evaluate this each seminar. So please provide ideas for our next seminar series. Yeah, that could be helpful.
Yes, we are looking for ideas for 2022. I can't believe I'm saying that year, but what would you like to hear about? So please let us know in the evaluations that you receive. There's a little section that you can just write the topics that you'd like to see us to see covered in the next year. I think we've touched on many of the most common topics, but maybe there are things that you think would be important to hear about. So please let us know what you think those are. So I'd just like to end by thanking Dr. Kotsopoulous. I think this was an excellent overview of some of the options that women have available, and some of the interesting and exciting new options that may be coming in the coming years in terms of options that are available to BRCA carriers for the prevention of breast and ovarian cancers. So I will end it there. Thank you to all of you again for attending. And again, please reach out if there's anything that we can help you with. And I look forward to seeing you all at the next talk in October. Thank you so much.
Listening.
Okay, have a good day, everyone. Bye-bye.